Okay, welcome everyone to our TRB AMS 50 Economic Development and Land Use webinar. Today we will be joined by Dr. Hamidi and Dr. Chen. To give you a background on our committee scope, this committee focuses on the impacts of transportation on the economy, environment, and society. It is concerned with efficient, effective, and equitable transportation systems, promoting competitive advantage, economic resiliency, sustainability for cities, regions, and societies. This committee provides a cross-cutting forum for practitioners and researchers to understand the interrelationship between transportation, economic development, and economy, land use, policies, and management approaches required to create sustainable growth at national, regional, and local scales. In order to become a friend of our TRB committee, please log into MyTRB at www.mytrb.org and go to committees, click on Become a Friend of a Committee, find AMS 50 and click on Become a Friend. And we encourage you to raise questions throughout this webinar. Please type it in the chat section and a moderator will read your question, or feel free to raise your hand virtually and we will unmute you. The last webinar at a glance, we covered machine learning in travel behavior research. Our speakers were Dr. Kockelman and Dr. Yan, and the YouTube for that is available. So without further ado, I'll go ahead and introduce our first presenter. Dr. Shima Hamidi is a Bloomberg Assistant Professor of American Health and Environmental Challenges. She is the founder and former director of the Center for Transportation Equity, Decisions, and Dollars, funded by the U.S. Department of Transportation at University of Texas at Arlington. She has written over 56 books and articles on urban form and impacts on individuals' economic mobility, public health, safety, emergence of food deserts, housing and transportation affordability, and location efficiency. The results of her research have been featured in more than 110 national and regional newspapers and magazines, such as Wall Street Journal, Washington Post, and CNN Money.
Thank you, Ilham, for the kind introduction. And thanks to you and to Dr. Kau for inviting us to this session. This is a topic of my interest, so please feel free to let me know in advance when my time is over so I can stop talking. Otherwise, I can talk forever about subway ridership, crowding, and population density. Basically, built environmental determinants of COVID-19 infection rates. We did a national study and test density and crowding on that national study, but the study I'm going to share with you today is about New York City, more specifically a more detailed disaggregated analysis. I'm an assistant professor of transportation and health at Johns Hopkins University, and I have been doing work on COVID-19 since the emergence of this pandemic. And the motivation behind this work and my work on COVID-19 has been really, the conversations, and I'm talking about lots of media pieces from New York Times, from Los Angeles Times, from Washington Post, from everywhere, even among the professionals, talking about is density, a problem for COVID-19? Does density make cities more vulnerable? And is density more desirable as or in a more complete form, a compact form of built environment compared to sprawling? Or which one is going to make us more vulnerable? Which one is going to give us a better public health and other quality of life outcomes? Well, years of research, hundreds of studies point to a more compact, connected, and transit-served built environment being the one that gives us a more desirable quality of life outcomes, and public health help us to be more physically active, walking, biking, taking transit, and to be less car dependent, when all of those were in question with the emergence of COVID-19. For example, this piece from Los Angeles Times talking about, is the Los Angeles form of urban sprawl make them less vulnerable and, make them more safe with regard to COVID-19. The other piece from Washington Post, I think, if I'm not mistaken, says the United States might have a secret weapon against coronavirus. And that's sprawl. Basically, when you have a low density of housing and population, then, that makes places safer and, less likely for the virus to spread out. That's what these pieces are talking about. This is another one from from CNN, I'm sorry, that says coronavirus is making some people rethink where they wanted to live. And those were pretty serious, even supported by, elected officials and decision makers. Like, in this piece, I selected a quote for you from the former governor of New York, Governor Cuomo, in an interview with CNN, saying that it's very simple. It's about density. It's about the number of people in a small geographic location allowing that virus to spread. Dense environments are its feeding grounds. Calling for, de-densifying the state of New York, and particularly New York City, both the governor, former governor, and the current mayor, both of them, saying that in future plans, we should prioritize suburban areas. We should plan for de-densify the city in order to be safer for future pandemics. So this is the question that we were facing at the time. Which one is going to make us more vulnerable for the pandemic and the overall quality of life and health outcomes? The images you see on the left or the one on the right? Do we want to make cities more pedestrian oriented or more car oriented? There were even real estate reports saying that people are moving out from the cities. Even among millennials who always in almost every national survey saying that they want to live in the cities, they were saying that they are rethinking where's their residential preference and where they want to live. So the same story happened for public transit. And if you look at the stories, some of the media pieces from the time, people were asking why are transit systems still running? And more specifically about New York City, saying that MTA, the New York City's transit agency, was major disseminator of coronavirus in New York City. There were lots of conversations about that, the majority of them negative. The subways seeded the massive coronavirus pandemic in New York City. Even, you could see in some papers, or New York City's subways blamed as major disseminator of coronavirus. We could see studies like that, questioning the entire public transit system, asking for that to be not prioritized for funding, for the funding to be channeled toward other modes of transportation that are safer for the pandemic. And so this was the motivation behind a couple of studies that we did. And what we found at the beginning, was just reviewing these pieces, is that they are not based on data and information. The argument behind them, most of them are pretty arbitrary. It's more of an opinion and observation than data-driven, conclusion. There was no evidence, no empirical evidence. No one has tested it before. So we wanted to see what the data says. And in the first study, we looked at density specifically, and we did a national study of 913 metropolitan counties in the US. And we looked at socioeconomic factors, we looked at health-related factors such as the rate of testing, healthcare facilities such as ICU beds, and we looked at as I mentioned, socioeconomic, racial composition, the important factors that literature even talks about, even the travel and the air traffic and the restrictions that were applied by different states and cities, in addition to density. And that was a national study at the county level. We found that there is not any statistically significant relationship between density and the COVID-19 infection rates. It was insignificant. And we found that the link between density and COVID-19 mortality rates was negative, meaning that areas that were more compact, connected, and transit served, they had a less rates or per capita rates of deaths, COVID-19 deaths, than areas that were more sprawling. But why is that? So we hypothesized an idea that was not tested on that study, and that was really important. At the moment, again, there was no empirical evidence of this idea, saying that density is different from crowding. I want you to look at these two images. The image at the bottom is Miami Beach in Florida. The image at the top is the same place. You might not believe it, but this was during the first wave of COVID-19 pandemic. This photo was taken in mid-April. This place is not dense. By any definition, it's very sprawling, as you can see here. All characteristics of urban sprawl, like single family detached. The street network is more cul-de-sac and dead end, and it's single use, zoned just as residential area, and really you can see it's sprawling, but it was not compact, but it was crowded. It was not dense, but it was crowded. And this place was, ended up being one of the hot spots of COVID-19 infection rates a couple of months later. Another example is from Collin County in Texas. So you can see this is an aerial imagery of the place. Pretty much, again, you can see the place is sprawling. It's low density, it's single use, it's street network, all of those factors. So it's sprawling, it's not dense, but this image shows one of the nightclubs in this county during the first wave of COVID-19, again around mid-April. Super crowded, but not dense. So again, we had this hypothesis. We never that was not tested, before, and we wanted to test with data to see which one of these characteristics make a place more vulnerable for the COVID-19 infection. We selected New York City because it was a place of high attention. You could see most of the articles and media pieces about about these built environmental factors such as density or even transit ridership, they would bring up New York City as an example of a city that's failed, to make a place safe for its residents. So we did this study at the neighborhood level. It was less aggregated than the previous study. And what was unique about this study was that we included population density, but we also measured crowding, which I'm going to show you in the next slide. So we had 2 or 3 variables to measure crowding. We had population density, and we had 2 variables measuring subway ridership. And we tested the relationship between these factors and the COVID-19 infection rate. But before that, I want to show you a hotspot analysis that we did during, when we were on the pretty much a peak of the first wave of pandemic in New York City, which was April 1st. And in May 25th, 2020, when the first wave was over. So if you look at the subway ridership data on the top image and the hotspot analysis of COVID-19 infection rate at the bottom, you can see that the two really, they not necessarily match together. Areas that are a hotspot but don't have much of ridership, and vice versa. The ridership is shown with those dots, the subway stations, and the darker the color of each station shows the higher ridership. Places like Manhattan, highest ridership, but they ended up being cold spot, and that was a bit surprising to see. But we wanted to test it quantitatively. So we included 2 variables of ridership. One was the baseline variable, subway ridership per 1,000 population. And the other one was percentage of changes in subway ridership between the 2 dates, pre-pandemic and during each of those times, April 1st, May 25th. But in addition to that, we also included socioeconomic variables such as percentage of Black population, percentage of Hispanic population, average household size, standardized SES or socioeconomic status index, which we created as our variables of socioeconomic and demographic variables. We included 3 variables of density. Crowding. One was the POI or place of interest, number of place of interest in each zip code per 1,000 population, and the level of crowding or number of people on each of those POIs. And we did that as the most disaggregated level, business by business. We used data from a source called SafeGraph to quantify and measure the level of crowding for every single business on these zip codes, and then we aggregated up to the zip code level to get this variable. The other variable of crowding we had was average household size. And that is, as I mentioned, a variable that shows overcrowded or crowded housing, the likelihood of crowded housing. In addition to the percentage of housing units in each zip code that were emptying out. That was one phenomenon that, again, was interesting in New York City, was that some neighborhoods had more than 40 to 50% of its population moved out of the city, going to places like Florida or California, their second home, to be safe, during the pandemic. And because they had the chance to do teleworking, they were able to do that. So that was another measure of crowding that we included, as well as the number of tests in our model. So what we found was that during the when we were at the peak of the first wave, which was April 1st, 2020, if you look at the p-values, subway ridership at the baseline and the changes in subway ridership compared to the baseline, none of them were significant. Both of them were insignificant. We didn't find any significant relationship between that and the rate of COVID-19 infection. However, what was the most significant, one of the most significant, as you could see, was SES index. It was crowding or POI, the level of business, crowded businesses, and also percentage of Blacks. Those three were the most significant. More interesting, population density was not significant. So population density was not significant, subway ridership not significant, changes in subway ridership related to baseline not significant, but socioeconomic and demographic variables turn out to be significant. We did the analysis for May 25, and the same pattern for subway ridership. Subway ridership, changes in subway ridership, not significant. Population density was significant. And again, the most significant factors: household size, SES index, percentage of Black, percentage of Hispanic. So here's the hotspot analysis of the COVID-19 infection rates in New York. The cold spot areas turn out to be Manhattan, which actually is the densest part of the city, maybe densest part of the US, but it turned out to be cold spot, where you see the other places in the city that are not as dense as Manhattan turn out to be hot spot. Why is that? I want you to look at this image. This image was taken from one of these hotspots. You can see that 5, 6, 7, 8 people are living in a small apartment. Most of them have service jobs, so they can't do teleworking. They have to go to work even during the peak times of the pandemic. They typically take public transit, and they don't have work policies for sick days and other policies that support them to stay home if they are feeling sick. So imagine if one of these individuals get the COVID-19 virus, being infected, it would not be that hard, it would be pretty fast that every other member of this household would also be infected. And that would be pretty much the entire neighborhood or community. The virus can spread out so fast compared to, again, places like Manhattan. Overcrowded housing is something that could make a difference. Versus, I want you to look at Manhattan. It's dense, but not crowded. It was one of the places that saw the highest percentage of people emptying out the neighborhood, right? They had the luxury to go to other cities in New York State, or even moving out of the state and going to other states because they could do telework. They had management types of jobs, they had tech jobs, so you could see it's not crowded, it's dense, but it's not crowded, and it turned out to be a cold spot. So what really matters, I think, is socioeconomic and demographic factors, much more than the conversations about density or even transit ridership. If you want to put it in the international context, I want you to see, for example, a comparison between India and Japan that I brought for you. India is overcrowded, but not dense, particularly, slum types of neighborhoods in suburban areas, places like this image. And you could see the rate of infection was, hierarchy in places like this in India pretty fast, versus in Japan, in Tokyo, you could see that, again, it's probably one of the densest places on the world, but not crowding. You can see small apartments, one or two individuals living in each apartment, and they have no problem of following social distancing advisories. And so, again, the conversation between density and crowding matters. But I want to turn the focus into public transit and see what really that means. Our findings regarding the insignificant relationship between public transit and COVID-19 infection rates. So during the same time, subway ridership in many cities, the mega cities on the world, global cities, was coming back to normal relatively compared to the pre-pandemic levels. For example, in Beijing, it was 6% relative to the baseline pre-pandemic. Berlin, 70%. In Paris, 45%. Cities were seeing a comeback for transit, but at the time that there was contact tracing in these cities, for example, in Paris, they found that none of the 150 infection clusters identified between early May and June were linked to the city's public transportation. Not even one. And as of July 2020, 4 out of 386 clusters, less than 1%, were linked to public transit. The same study in Australia.
Sorry
Yes.
to interrupt you. If we can wrap up the presentation in a couple minutes, that would
Sure.
be.
I will wrap it up. Yeah. The same story in Australia. Study of coronavirus clusters in April and May did not tie any of those clusters to public transit. And the same for Hong Kong. Again, the studies show that it has not seen a big outbreak associated with public transit. Same as Tokyo. So all of these were mega cities with thousands of people using public transit. But, it doesn't mean that public transit is safe. But, what would be the recommendations, or our recommendations with regard to public transit, is that it could be turned out to a safe option for people, particularly vulnerable transit-dependent population who have no other choice but to take public transit. How that's possible? If you look at the some of the action plans of public transit agencies that were more successful, for example, presence of high-touch, surfaces that makes public transit more of a dangerous place, cleaning, and disinfection, and a good communication and contact tracing, incorporating public health into service planning, for example, clear guidelines on cleaning activities. As you see, for example, New York City has done tons of that, and many other cities followed. Or as I mentioned, effective communication, or helping people to avoid crowding in public transit, helping them with apps and technologies like what the Washington, D.C. Public Transit Agency did, creating an app to give people a notification when the coming train is crowded, and or coming bus, and give them an idea of how much is crowded and how much they have to wait for it to be less crowded. So, if I want to conclude with this slide, I want to highlight a couple of points, and then end my presentation with a quote from the published paper. We found no evidence that a higher per capita subway ridership is related to the COVID-19 infection rate. On the other hand, the racial and socioeconomic disparities were among the most significant predictors of spatial variation in COVID-19 per capita infection rates in New York City, even more significant than variables such as place of interest or crowding factors, density and nursing home bed rates. The same story is applicable to density, particularly during the first wave in New York City. And so if you want to, make a conclusion out of these findings, the fact that density and associated public transit service is unrelated to confirmed virus infection rates and inverse related to confirmed virus death rate is important, unexpected, and profound. It has implications for community design, regional planning, transportation expenditures, urban redevelopment, tax policy, congestion pricing, smart growth, affordable housing, and nearly every other front burner issue important to planners. Thank you. I would be happy to answer questions. Hope I'm not going much over time, Ilham.
No, that was excellent. Thank you so much. But since we want to leave time for questions and comments, that was fascinating. Thank you so much.
Sure. So let me start sharing.
Do you want, because you said you may do a brief introduction, or should I just continue?
Okay, so I think maybe we can allocate the questions at the end of both presentation. And so let me briefly introduce Dr. Peng Chen. And Peng is assistant professor in the School of Public Affairs at the University of South Florida. And he specializes in shared mobility, personalized incentives for travel behavior change, and the relationship between travel behavior and health. His current projects are funded by the Center for Congestion Reduction, the Center for Transportation Equity Decisions and Dollars, and the Center for Transportation Environment and Community Health, all of which are funded by US DOT and the US Department of Education. He has published 30 peer-reviewed articles in the fields of transportation planning policy, and he served as a social editor for Transport Research Part D, and he obtained his doctoral degree from the University of Washington. And welcome, Dr. Chen.
Okay, so thanks for Jason's introduction. This study was published in 2020, and actually 2021 is on Part D, collaborated with my prior master's student, Songhua, who right now is a PhD candidate at the University of Maryland. So this paper, basically we look into this kind of dynamic change of the transit ridership in Chicago in 2020. A lot of those details, especially in the methodology part, actually, if you have any question, you may contact Dr. Hu is the primary author of this paper. Before I jump into my research question, I just want to do some quick feedback, because I think the issue about the ridership of transit in the US actually has been significantly changed. And this is from some data I just obtained. And for Chicago's part, as you can see from here, from 2021 in June, actually the ridership has already come back. With the large scale of vaccination, so in the US, roughly in 2021 March, we have large scale of vaccination, and despite even Delta variant has been kind of large scale spread, but still we see the ridership comes back, and then the Omicron, the new variant coming, but right now we see some decline in the ridership. But overall, the period that we study for this, we taken for this study was in the year of 2020, and you see a huge decline from March in 2020, and recovers, so for the whole period, the huge decline, about 1 year. So I just want to send a reminder, our research, most of those conclusions may only apply for this period. So I will have I have an introduction of this study and then literature review and the research design, which I think is a little bit complicated, but still I will elaborate why we do this research in this way, and then some results and discussion. So I have to acknowledge Dr. Shiha's introduction, and we all noticed that the ridership has been hugely declined after the outbreak of COVID in the US. And this decline is not spatially evenly distributed across different social groups and across locations. And we take Chicago for empirical analysis. There are two reasons. One part is Chicago is one of the leading transit metropolis in the US, so among the top 6. I think only after New York in terms of ridership and the years of services and also the scale. And the other reason is Chicago kind of have the ridership data publicly available for 20 years. So our research question is we try to identify what the factors can explain the transit ridership decline after the outbreak of COVID-19. And we also want to identify what other factors can help explain this decline. So for in the literature, because that was in 2020, at that time, not so many studies have done the impact inference. So basically we do a causal inference model rather than a descriptive or cross-sectional model or longitudinal. So this is the causal model part. We don't see any empirical study. And so in this study, we consider a lot of factors, including some external factors. So very similar, we also looking at like density and also social demographic factors, some contemporaries. We also look into some internal factors that may relate it to the station type, the service frequency, because we know the COVID, actually many transit agencies see the shortage of funding and they cut on the services. And we also look into the reliability, comfort, and park rider facility location and fail. That's other internal factors. So after the COVID, especially in March 2020, the maximum decline of transit ridership was about 92% in New York and 77% in DC. And because in those cities, the low-income people who on the critical activities such as like service, they are highly reliant on transit and they have to work. So there are some social disparities we notice before we will dig into this study. So as I mentioned, why we chose Chicago, another reason is Chicago was one of those states after the COVID outbreak, who was the leading state, observed this high level of infection in the nation. And then after period, then the California and Texas and Florida then peaked. But that's why we consider Chicago was for the empirical study. And this figure shows that for this, for 20 years, we see this Chicago has the ridership somehow stabilized and increased over the years. But in 2020, as you can see, we have this kind of room in figure. You see from March, we see the ridership huge decline. At the same time, the infected cases somehow fluctuating, but significantly increased at that time. So that's why we think this period deserves our attention. However, it's kind of sudden event, so conventional time series model cannot capture this kind of sudden change. So we take this airline as in Chicago for our empirical analysis. So then, because this kind of sudden change are hard to analyze, so we incorporate a complicated modeling framework that consists of 3 parts. The first part, we use the Bayesian structural time series analysis. This actually developed by Google. So we have 3 parts, and I will further elaborate later. And then the second part is the impact inference, which is a causal modeling part. And the last part, we use the partial least square regression. So for the data part, we have some time series data, including the weather and holidays, because those factors significantly impact ridership. And the other part of the spatial data, including the land use data, COVID infection related data, social demographic data, and transit facilities. So I will further elaborate our research design. The first part is about this Bayesian structural time series part. For this part, we have 3 actions. The first part, the first one is common filter. The second one is spike and slab regression. And third part is Bayesian modeling averaging. So for common filter part, basically we try to identify the trend of the trend ridership data, and we also incorporate the spike and the slab regression that can help us to incorporate external factors to do the prediction for ridership data. So basically we use the existing 20 years data as the data to set up the function to train the model. So it's more like a ARIMA model we can forecast and predict, but it's not solely based on transit data alone, but also incorporate external factors. That's why we consider this BSTS for model for prediction is more accurate than the conventional ARIMA model. And then for the second part, we do the causal inference because we have the model trend, then we do the prediction. However, with observe the data, we see a huge gap, and then we use this gap as the impact. Then we use this relative impact, and we try to see what are the other factors impact on the ridership. That's how this relative impact is defined. So it's basically the change, the expected change from COVID. That's why this intervention make an impact on people's on the ridership. And for the last part, we use this partial least square regression is because there's significant kind of high collinearity among some variables, and partial least square is a model that can account for multi-collinearity issues. That's why we have this complicated analytical framework. So as I mentioned, the BSTS is basically incorporated 3 functions, but can capture trend, can include the external variables for time series estimation. And the second part is a causal inference, and then we also account for multicollinearity with this research design. We consider a lot of factors. For the land use part, we have commercial, industrial, institutional, open space, and residential. We also calculate the land use mixture. And for the COVID related features, we have the number of cases and number of deaths, included in the model. And this data have multicollinearity, and that's why we use partial least square. And for the social demographic factors, we obtained the data from 2018 American Community Survey. So it's at the census block level. We have factors as male, age, race, income, and education, and also job type. And then the density measure also included here as population density, employment density. And regarding transit services, we have the transit frequency and the number of trips passing through each station incorporated in this data. So here, I want to highlight this figure. I think the first 3 just show you those factors impacted by trend, week, and also the months. I don't have much to elaborate on the first 3, but we'll pay attention to this part, the prediction part. So this blue color, or the green color actually shows you without intervention. So we use the BSTS model to do the prediction. So without intervention, we will assume the ridership will follow the pattern. However, this is the observation, this is real data, because this is the result impacted by COVID. So you see a huge gap between the prediction and observation. And this is the aggregated residual, and you see somehow this ridership has been changed, and this shows the fluctuation of the ridership data. So in this figure, this shows if without COVID, this is the transit ridership data should look like. And this response is actually to observe the pattern of the ridership data. So we don't see the fluctuation since March 10th. And this one shows the piecewise impact. So that's for the pre-intervention after COVID. That's after the COVID intervention part. So this is aggregated pattern from March 10th to about May. So basically this, so this figure reduce this part that can become the relative impact, and that's how the relative impact is defined and calculated. That's basically based on Bayesian time series estimation. We get the prediction, and then we observe the data, then we get the relative impact part. So we set this relative impact as the dependent variable, and then we incorporate the external variables, explanatory variables, and then that help us to do the model. And there are 7 stations that has a posterior probability greater than 10, and that's the airports, terminals, or interchange hubs with higher random fluctuation. So that's basically some detailed part of this study. So here I'm showing you the model that finally we use the partial least square for the regression. And there are some significant factors, and I will skip this part, and please trust our interpretation in the next slides. So for results part, the first conclusion is the percentage of people of a higher college degree or higher has the largest negative coefficient, followed by the median household income and the percentage of white people, and the percentage of Black people that has the largest positive coefficient. So some disparities among different racial groups has been identified. So I think this part can be explained by that highly educated people have more choices. They can afford to have cars, and they can also may have a higher opportunity to work from home. And the second conclusion here is the number of positive cases and deaths were both positively correlated with the relative impact. The third conclusion here is among various types of land use, only the percentage of commercial land use presented a significant negative impact. So this can be explained by people constrain their shopping frequency during the COVID. Across different age groups, the percentage of people aged from 24 to 40 was negatively related to the relative impact, and the percentage of people aged from 40 to 65 show a positive impact. The number of jobs in trade, transportation, and the utility sectors present positive effects, so they are more likely to expose to risky environment. So I think we proposed a somehow complicated but with some cutting edge analytical approach into this analytical framework by incorporating time series prediction, causal impact inference, and also spatial analysis together. And we quantify the effects across different explanatory variables on transit ridership during the COVID pandemic, actually the outbreak. So this study not only examined the significance of independent variables, but also sought the magnitude among different relationships. And our main findings, the first one is for ridership declined more in regions with commercial lands, and also the higher percentage of white, educated, high-income individuals. So this part, basically, so there's some difference shown in the land use and also some disparities across different socioeconomic groups. The regions with more jobs in utility sectors presented a smaller decline. That also corresponding to the first presenters, there are certain inequality presented for people of different employment status different. So people who serve the public, doing more jobs for the critical activities, they are suffering more exposure to COVID. And this study also confirmed the significant positive relationship between transit ridership and also the number of COVID-related deaths and cases. So for positive implications, we suggest we should adjust the service level based on the socioeconomic characteristics and the spatial needs. So especially for people who are living in the more dense, crowded area and they have a highly dependence on transit, this kind of service cannot be simply cut down. Especially think about if the service is cut down when these people, they don't have other options, they still have to ride transit. That will make transit more crowded given the reduced service. And the second implication is we should adjust the maintenance practice to better protect the riders and the transit workforce. We should allocate more funding to agencies who operate transit in the region with a higher density of vulnerable group, or we should provide alternative transportation or mobility services to the vulnerable groups during the COVID. And the fourth implication is the deep socioeconomic inequality deserve attention, should more focusing on the underserved population to help them address mobility challenges following the stay-at-home orders and the new social distancing norm. So all these conclusions were based on the ridership in 2020. So I don't think this conclusion still apply to a great extent, given right now it's kind of under new normal and the ridership has already come back. So that's what we have for this study. I'm welcome all kinds of questions you have regarding this study. Thank you.
Okay, thank you very much, Dr. Chen. And so I think for the audience, and if you have any questions, I think maybe it's time for you to type in the chat box. And being a moderator, I want to take this privilege so I can ask my first question for both of you because I think it's related. You know, in Shima's presentation, you know, she found the transit ridership has nothing to do with the action rate. Okay, and then in Chen's presentation, you know, he found, you know, the transit ridership has a positive relationship with the number of cases. So you can see, you know, when we use a different measure, and then we find kind of you know, somewhat different conclusions. I mean, which one is better? I mean, do we use the affection rate or should we use the number of cases? Maybe, you know, both of you can offer some of your opinion.
Sure, happy to share my thoughts. Well, I think the rates, per capita rates, is a much better measure of any variable that's related to, you know, when we want to, you know, measure something about population than the number. Particularly when you look at the zip code level analysis, because you know, the number of cases relative to the population of the place show, you know, to me it shows a much more standard way of comparison. Meaning that, like, if you kind of have a population consistent in both places or the same, which one is going to have a higher rate? But if you just look at the number and not the rate, then that's what will give us, like, the New York as the hotspot, you know, a major place for COVID-19 compared to places like California or Florida. But if you just use the rate, you will get an absolutely different you know, model, an absolutely different conclusion. And to me, rate is a much more informative and better measure of variables like COVID-19 related, factors.
Hi, Jason. So I think regarding this question, I think it's by case. And our study, because our dependent variable is ridership, so it's a count variable rather than a rate variable. So I think that's why we should include the number of cases as the explanatory variable that will match. However, if our dependent variable is a rate, then I think we should incorporate a rate as a explanatory variable. That's comparable. Otherwise, I don't think this really follow the statistical concern addressing here.
Okay, so that means for different purpose of the study, we use different variables, and then we may reach different conclusions. So that means when we interpret the results, and then we need to be a little bit cautious, right? And okay, that's great. So I think maybe now I can turn the Elham, and can you try to elaborate the question by Matthews?
Yeah, so he asked a question. Thank you for a great presentation. Like in a lot of the literature on the built environment, you've made a really compelling case. SEC and self-selection plays critical roles as mediating process. Comparing the relative magnitudes of different variables, it can often depend critically on model specification. Did you estimate the standardized model coefficients to compare the relative impacts of SEC and BE impacts? And how sensitive were your broader findings with respect to how SEC was specified as a composite index versus a series of variables? For example, in the final model population group, race was separate from the rest of the composite index.
That's a great question, and it does matter how you define your socioeconomic and demographic variables. There are so many of them, and if you want to include every single one, you are going to end up with multi-collinearity and other problems in the model. So the way we define that, if you look at the public health literature, like built environment and public health, there is a pretty standard way of measuring that. Something that's established by NIH, National Institutes of Health, and has been used by hundreds of studies that looked at built environment and health. And that is an index called Socioeconomic Index. And the socioeconomic index has like 7 variables that would give you variables related to income, monthly housing rent, monthly housing cost for owners. It would give you social factors related to individuals, everything but demographics. So then we ask, what are the demographic factors that make sense or literature suggests that should be included in a study, with a focus on COVID-19? There were 2 important factors. One was race and the other one was age, right? So for race, we included the percentage of Black, and for age, we included the per capita rates of nursing homes. As places that were really important, particularly in New York City for the higher number of infection. We went with the standard way of measuring each of them. The only variable that we a little bit played with in our model was race. So we included Hispanics, we included Blacks, then we also looked at percentage of non-whites. And our analysis shows that percentage of Blacks and Hispanics are responding the best to the model, and with regard to the model fit and measures that you have for measuring the quality of the model. So that was our rationale for choosing those set of variables.
Okay, great. So, and Shima, also I had an early question regarding the POI and per thousand people. And I think you treat it as a crowding factor, right? So why is it not a density factor? Because I think if, this is really kind of the establishment density. Is that right?
That's a great question. So I should have not called it number of POIs. It was a number of POIs that we factored the level of crowding in each POI for that variable. So for example, if I can just for a second share my screen, that would be a variable that measures like how many people, how many viewers or how many visitors each business will have during that time. So by day and by hour, like peak hour, like do we have all of these people at the same time at the same place in an enclosed location? And we hypothesize that that is really what makes the place much more vulnerable to the pandemic than just the simple measure of employment divided by land area. So that was, the number of POIs plus the level of crowding in each POI or number of visitors in each POI.
Hi, Jason. I also want to add some comment to the impact of density on the COVID spread. To me, I think this can be some limitation of the study because people who really are infected in the space cannot be tracked, especially in the US context. So maybe I'm infected in downtown. However, when reporting the case, that will right now tracked to their home and counted as based on their home zip code. So the time they were infected or exposed was not captured, or maybe they are infected on the transit, but still finally the case is go back to their home. So I think that can be the limitation of the data when we try to capture such relationships. So that's why I think we cannot really attribute this kind of fault to transit or density. And even right now, if you look at, so I think for Dr. Hamidi's presentation, we see Beijing and Hong Kong, at least for a long time, the cases were low, but I think that should be attributed to China's policy. Like right now, I haven't returned to China for 3 years. That's the 28 days quarantine. It basically tried to keep the case at zero. In China, it's kind of this strong, control, and they do aggressive tracking. They do quick testing for people in the whole city, like 10 million people just in 3 days. And also people have stayed at home for a whole week without going out. So this kind of aggressive policy really result in the difference rather than explained by density or transit services. I think the question is really complicated. I don't want to further explain, but overall, I think it's very hard with simply to attribute that density or transit services result in a lot of difference here. So
okay.
that would be my comment.
Thank you for the comment. If I want to respond to that comment, I would say that a couple of things. First, this study was done during the first wave of pandemic, which was really March, April, and May of 2020. At that time, I think most places didn't have an aggressive measures of contact tracing and all of those. Everyone was kind of surprised and shocked by the magnitude of the pandemic. Second, we didn't test those cities. We test New York City. So, I think what we have as our findings and, the analysis that was supported by data and our results could say, pretty much the story about what happened in New York City. And the third, I would say that I agree with you that maybe people who are in this place, like this crowded nightclub, they don't live in the same neighborhood. But this level of crowding impacts locals. So, even though these people will not live, there are still local people who are here. And if 1 or 2 people are infected and they spread out that infection to this crowd, and even if a couple of people who are local, more likely to be from the same neighborhood, could spread it out to the rest of the neighborhood. So it matters when you have the crowding. The last point I want to mention that our model, we controlled for the spatial relationships between these different places. And we did the spatial econometric because, as you probably know, there's a special autocorrelation with regard to one neighborhood versus another. And so our models were spatial econometric models that controlled for the spatial relationship and that spatial autocorrelation.
Okay, thank you. And so I think maybe I will just ask the last question, and for both of you. And I think for many transit planners, the most important question is about the future of the transit industry, right? So because of this pandemic, and also I think your analysis are based on the kind of the old data, right? Just a couple of years ago. And then, we have been, in the pandemic for more than 2 years, and then the pandemic become endemic. And then, so thinking about maybe 5 years later, so what's the future of the transit? What's your guess? Okay, what's your ideal guess, about the transit future?
Dr. Chen, you want to go first?
So I think this can be complicated because I think in the US, we all notice that transit is declining, is the trend. And I think because I think only 3 cities, based on my knowledge, that only Seattle, and then Texas, I think that's Houston. And then I forgot about the third one. They see some ridership increment in recent years, but all the other cities significant decline. So I think that's the trend. And I think this COVID actually accelerates this trend rather than, reverse this trend. So I'm not quite positive towards the future of transit, but we also see the rising new modes such as paratransit, microtransit. So because this kind of large bus, it's not quite efficient, but people if change to more flexible on-demand services, I think that's the future, which is more promising, another form that fits to the US context, because overall in the US density is low. And also we know in the last 2 years, many people move into Florida and Texas, and the top 2 see people, the reduction of residents, the top 2 states are New York and California. So my guess will be like in the future peer-to-peer carpooling, and then also with, I don't know how long the autonomous vehicle can really load it, but I think that's the future. This more peer-to-peer carpooling, and then microtransit, paratransit that can be more popular in the future, and the ridership is I think it will decline. It's just my guess.
And I would add that we should also think about these changes in lifestyle that we've seen in many people's now working from home has become the new norm, and many companies, are adapting their working environment for that, at least partially, and many of them planning to have that for a long time or even permanently. So we are gonna have a decline in a ridership continue to be the case for quite a while. But one positive I want to just mention that to me, good news is the focus on public transit on the infrastructure bill that we've seen recently. That I think if that funding is being used in an effective way, to me, in a way that connects the existing public transit to some of the micro-mobility options, to really make a network as a whole, to make them one network, one unit. So we can have a public transit system that could be comparable to driving in terms of comfort, efficiency, speed, all of those factors. Then we can be optimistic about public transit. And I hope we see that happen, at least to some extent.
Okay, thank you very much. And based on your response, I see the transit may experience some difficulties in the coming years, but also we also see some opportunities for reorganizing and also reintegration with other modes of transportation, and also with the support from the federal government. Hopefully, we can see the transit industry will recover fast, because I think the transit is still the backbone particularly for the large cities. We really need to have sufficient and efficient and effective transit to make the large cities Great. So I think thank you very much, and Dr. Chen and Dr. Hamidi, and for your wonderful presentation and your nice response to our questions. And hopefully, we will see you in the future webinars. Thank you.
Thank you for inviting us.
Thank you. Thank you for the invitation.
Okay. Bye-bye.
Bye.
Goodbye.